Bismillahirrahmanirrahim. I'm Dr. Muhammad Daniel Iqbal. The topic of my presentation today is erectile dysfunction. Learning objectives are epidemiology, history and clinical examination, etiology, and investigations. Erectile dysfunction is defined as inability to attain and or maintain an erection sufficient for satisfactory sexual intercourse. Erectile dysfunction is estimated to carry an overall adult male prevalence rate of 10% to 20% worldwide, with majority of studies reporting rate closer to 20%. The prevalence of erectile dysfunction increases with increasing age, 1 to 10% for men less than 40 years, 15% for 40 to 49 years, 30% for men age 50 to 59 years, 40% for men 60 to 69 years, and 50 to 100% between 70 and 90 years. Incident erectile dysfunction may indeed inform the risk of subsequent disease, morbidity, and mortality. Men with ED are 45% more likely to experience a cardiac event on 5 years follow-up. A study in Taiwan showed that cancer risk was 1.4-fold higher in ED patient than in patient without erectile dysfunction during a 5-year follow-up. Major erectile dysfunction risk factors include diabetes, hypertension, cardiovascular disease, hypercholesterolemia, BPH, obstructive urinary symptoms, increased BMI, more than 30, physical inactivity, current cigarette smoking, antidepressant use, and antihypertensive. The potential causes of erectile dysfunction.
Before we move on, Daniel, can we quickly summarize the pathophysiology of erectile dysfunction? Dr. Mustaq, what is the pathophysiology? What is the physiology of normal erection?
Sir, there is initially cavernosal arterial dilatation that lead to
caused by
parasympathetic system.
Which neurotransmitter? Which hormone? Nitric oxide. Right.
And also there is a relaxation of the sinusoidal venules that lead to the engorgement and lead to the erection. It causes the compression of tunicle.
There is inflow of the blood. Yes. And what else?
And then it causes the compression of the tunicle venules.
Yes.
And that help in maintaining the erection.
Then what happens after ejaculation?
And there is detumescence caused by the sympathetic system.
What does sympathetic system do?
It increases the tone of the arteriole.
It constricts the arterioles. That allows the blood to move out, and no blood is coming in. That causes. Okay. So anything which impairs any of these steps will lead to ED.
Potential causes of erectile dysfunction is commonly categorized as psychogenic, organic, and mixed. In psychogenic, there is presumed psychological or interpersonal determinant. In organic, there is endocrine, neurological, or cardiovascular cause. In mixed, there is coexistence of both factors. The cornerstone in evaluation of ED involves detailed case history, professionally from both patient and partner, physical examination, and proper laboratory tests. History taking includes medical history, sexual and psychosocial history. All discussion of sexual matters should be done privately and confidentially, and clinicianly is required to express trust and concern as well as non-judgmental manner that epitomize doctor-patient relationship. In medical history, age should be asked, comorbidities, common medical condition such as dyslipidemia, neurological disease and thyroid disease history, and medical conditions, history of trauma involving aspects of body, pelvis or genitalia, for example spinal cord injury, pelvic surgery, radiation, sexual history, sexual injury, and drug history. The drugs associated with erectile dysfunction includes antihypertensives such as beta blockers, thiazide diuretics, antidepressants such as SSRI, tricyclics, antipsychotics, phenothiazines, antiandrogens, LHRH analogs, certain, and anti-ulcer drugs such as H2 blockers, cytotoxic agents, cyclophosphamide, methotrexate, opiates, morphine. Sexual history, the two circumstances should be asked. The circumstances associated with erectile dysfunction, difficulty, which include performance anxiety, inability to perform with designated partner, availability of partner, interest and health of partner, changes in medical status or other events relating to onset of ED, previous attempts to manage problem by patient or another caregiver. The circumstances for achievable erections should be asked, which include erections on awakening and role of self-stimulation. Psychosocial history includes the presence and interaction of mental health problem, emotional stressor, and interpersonal relationship difficulties, and of past and present should be asked. Additional question may be asked relating to occupational status, financial security, family life, and social support, which also influences sexual function. In absence of organic risk factors, a primary psychogenic erectile dysfunction causation should be suspected. Further support to diagnosis may follow confirmation of known coital erections. Then the quick review of psychogenic and organic ED. In psychogenic ED, there is sudden onset, while in organic there is gradual onset. In psychogenic, there is a complete immediate loss, while in organic there is gradual progression. In psychogenic, there is situational dysfunction, while in organic there is global dysfunction. In psychogenic, waking erections present, while in organic, waking erections are absent or poor. Then there are certain questionnaires and sexual function symptom scores. The most commonly used is International Index of Erectile Function, which include 15 items that address five domains. One is erectile function, and then orgasmic function, sexual desire, intercourse satisfaction, and overall satisfaction is assessed. Other symptom scores are like brief male sexual function inventory score, at the Center of Marital and Sexual Health sexual functioning score, the changes in sexual function questionnaire, the erectile dysfunction inventory of treatment satisfaction. This is most commonly used IEF score. Physical examination.
Okay, Jalal. What is the scoring of IEF? What is normal? What is abnormal? Have you gone through IEF? Anyone? Dr. Kamal? And why we use this IEF thing?
Classify it to the mild to moderate or severe erectile dysfunction and treat accordingly.
Can we understand the cause of ED based on this questionnaire score?
Cause, there is no cause related question.
So these symptom scores are only to identify whether ED is there or not. But it doesn't give you any idea that what is causing ED. It is similar to the IPCS score of VPH. Right? You only identify that there is a problem, you can quantify how severe it is, but you cannot know what is the cause. So in order to evaluate the cause, you have to do other things.
And then physical examination, basic anthropometry such as height, weight, waist circumference should be taken. Assessment of body habitus should be done. Classically distinctive body habitus should be noted, such as in Klinefelter syndrome, and physical signs of hypogonadism should be checked, like gynecomastia and poor masculine development. Blood pressure monitoring should be done. Testicular exam should be done, so to check the size of the testes. Examination of penis should be done. Detection of penile deformity, microvenous, congenital chordae, Peyronie disease, related fibrotic plaques in corpora cavernosa should be identified. In vascular examination, abnormal femur or pedal pulse should be checked. In neurological disorder or diabetes, abnormal genital or perineal sensation or bulbocavernous reflex may indicate the presence of peripheral neuropathy in diabetes. Then laboratory tests, baseline tests such as CBC, UC, and fasting glucose or HbA1c should be done. Lipid profile should be checked. testosterone level, especially in morning time blood draw. Testosterone should be done. Prolactin measurement, thyroid function test, PSA testing, and dipstick analysis of urine may show glycosuria, which suggests diagnosis of diabetes. Then there are certain specialized evaluation and testing for ED. In vascular evaluation, there is a combined intracavernous injection and stimulation. This test includes intracavernous injection of vasodilatory drug or drugs as a direct pharmacologic stimulus combined with genital or audiovisual sexual stimulation. Erectile response is observed and rated by independent assessor. It bypasses neurogenic and hormonal influences involved in erectile response and allows clinician to evaluate the vascular status of penis directly or objectively. A normal cavernosal injection and stimulation test means normal erectile hemodynamics. Alternative diagnosis may be considered then. False positive result may occur in 20% patient with borderline arterial flow, which includes arterial flow between 25 to 35 cm per second, peak cavernous artery systolic flow on duplex ultrasound. False negative result may also occur most commonly due to inadequate dosage. And then there comes a duplex ultrasonography. It helps visualize the dorsal and cavernous arteries selectively and perform hemodynamic blood flow analysis. It indicates direction of blood flow within vessel with the red signal, designated direction towards the probe and blue direction away from the probe. Cavernous arterial insufficiency is suggested when peak systolic velocity is less than 25 cm per second. Peak systolic velocity consistently greater than 35 cm per second means normal cavernous arterial inflow. Then there comes vascular resistivity index. It is measured by peak systolic velocity minus end diastolic velocity divided by peak systolic velocity. An RI more than 0.9 has been associated with normal penile vascular function. If it is less than 0.75, it is consistent with veno-occlusive dysfunction.
So if someone has these three tests which we have just discussed, intracavernosal injection and stimulation, duplex and vascular index, if they are all normal, what does that mean? The patient still has AD. Psychogenic? No. Dr. Naseem? These tests are used to evaluate what? Which system? Vascular system. Right?
Neurological as well as endocrinology.
Yes. So there are three systems involved in causing ED. One is vascular system, the second is neurological system, the third is hormone. If someone has normal intracavernosal injection and stimulation test or normal duplex test, that means that he has a normal vascular system in the penis, but it doesn't mean that he has a normal neurology or normal hormones. If he is hypogonadic, these tests will be normal, but patient will have ED, right? So they only exclude vascular causes of ED.
Then dynamic infusion, cavernosometry and cavernosography. It refers to functional hemodynamic and radiologic assessment to corpora cavernosa. Is indicated in trauma patient where site-specific vasculogenic leak is suspected. When used, it generally precedes the consideration of corrective penile vascular surgery. Then penile angiography. It describes the anatomic detail study of arterial vasculature of penis. It is commonly reserved for young patient with ED secondary to traumatic arterial disruption or the patient with history of penile compression injury who is being considered for revascularization surgery. In penile angiography, we inject the radiographic contrast in internal pudendal artery. The anatomy and radiographic appearance of iliac, internal pudendal and penile arteries are evaluated and documented. Inferior epigastric arteries are frequently studied as well to determine their suitability for use in surgical revascularization. Then there are some historical investigation studies to detect penile blood flow, which include penile brachial pressure index, radioisotopinography. These both are not commonly used nowadays. Penile MRI imaging to check the anatomic details, and cavernous smooth muscle content, in which we do multiple biopsy in cavernous muscle, and reduce muscle amount means is a cause of ED, but it is not also commonly used because it's invasive. Penile tumescence and rigidity monitoring. As a standard sleep laboratory, nocturnal penile tumescence and rigidity testing applies nocturnal monitoring devices that measure number of episodes, tumescence, maximal penile rigidity, and duration of nocturnal erection. Normal NPTR include 4 to 5 normal erection episodes per night.
So if someone has normal NPTR, what does it mean? It rules out what? Only psychogenic ED. It rules out psychogenic ED, and there is organic.
Then audiovisual and vibratory stimulation test, in which erotic stimulation by explicit videotape material with monitoring has been used as a reliable as well as time and cost effective alternative to NPTR for differentiating between organic and psychogenic ED presentations. It is also considered more physiologic consistent with erectile behavior while awake. Then neuroimaging in PET scan and functional MRI are in association with sexual stimulation are used to detect certain brain regions in which are centers for arousal, which include anterior cingulate, insula, amygdala, hypothalamus, and secondary somatosensory cortex.
In which type of patient you would like to do these testing? This is higher brain centers. In patients with CVA, MS, Parkinson, the diseases which affect the higher brain centers, in those cases you would like to do these tests. After evaluating the vascular system and hormones, if everything is normal, then you can go for it.
Then a neurological evaluation, which include two systems: somatic nervous system and autonomic nervous system. In somatic nervous system, biothesiopatry, genito-cerebral evoked potential, dorsal nerve conduction velocity, and sacral evoked response, bulbo-cavernous reflex latency will be checked. In evaluation of autonomic nervous system, heart rate variability and sympathetic skin response, penile thermal sensory testing, and corpus cavernosum electromyography and single potential analysis of cavernous electrical activity can be done. Then hormonal evaluation. Three major systems should be evaluated. First of all is testosterone deficiency, hyperthyroidism, and diabetes. Diabetes cause altered modulation of androgen function.
How does testosterone deficiency cause ED? Dr. Naseem, what is the role of testosterone in maintaining erectile function? Dr. Usman Jr., what is its central effect and what is its local effect? Okay, so testosterone has this general effect on the sexual function. It has a role in arousal and stimulation for sexual activity, and it has a role in the growth of genitalia, the maintaining the growth and function of the penile tissue, the detusor muscle, the cavernosal muscle, and everything. So it has this whole background role. It doesn't specifically affect a single function of erection. It has this whole background role. So if testosterone is low, everything's going down. And how diabetes cause ED? Dr. Najam, how diabetes cause ED? Dr. Noman?
Diabetes has number one vascular pathology, can cause vascular pathology, arteriosclerosis. Number one, there is a decreased blood flow in the penile vessels.
Okay.
And second, when it acts on the arteriosclerosis, it can cause mop out the receptors on the endothelium so that androgen cannot.
So it basically causes endothelial dysfunction, which is central to the function of erection. And what else it causes? Which other system it affects, which leads to erectile dysfunction? We said you need to have a normal vascular system, you need to have a normal neurology. So diabetes affect neurology as well. Diabetes causes peripheral neuropathy, and that can affect the erectile function as well. Right? So in this context, if someone has ED, he may have what else?
Diabetes or cardiovascular disease.
He may have diabetes, he may have cardiovascular problems, he may be at risk factor for at risk for CVA. Right? So if someone comes to you with ED, he may have some underlying problems, because ED means that he has some vascular problem going on in the penile tissue, and if it is going on in the penile tissue, it must be going on in the heart, in brain vessels, in kidneys and everything. So whenever a patient with ED comes to you, you have to evaluate him for other risk factors of vascular dysfunction.
Serum testosterone measurement. Testosterone circulates in three fractions: free, tightly bound to sex hormone binding globulin, and loosely bound to albumin and other protein, which is majority, 67%. Free testosterone and albumin bound portion make up bioavailable testosterone fraction. The relative concentration of carrier protein, sex hormone binding globulin and albumin modulate androgen function. Then gonadotropin measurements. Measurement of serum gonadotropin helps to localize the source of hypogonadism. Testosterone release involves integrative activity of hypothalamus, pituitary and gonadal axis and its regulatory feedback mechanism, and disruption at any level of this axis may account for hypogonadism. In primary hypogonadism, there is low level of testosterone which cause decrease and negative feedback to hypothalamus and pituitary, which cause increased secretion of LH and FSH. In secondary hypogonadism, there is low or normal level of LH and FSH with low serum testosterone level, which is usually in central disorder. Then serum prolactin measurement. Hyperprolactinemia causes suppression of GnRH from hypothalamus, impairs the pulsatile LH secretion required for serum testosterone production by gonads. Hyperprolactinemia causes loss of sexual libido independent of circulatory level of testosterone. Suspicion of hyperprolactinemia is raised in patients with low serum testosterone and lower inappropriately normal LH. MRI can be done in patients with severe central hypogonadism and suspicion of pituitary disease. It is due to rule out the mass lesion in brain which cause central problems. Then serum thyroid function test. Hyperthyroidism is associated with erectile dysfunction. Increased thyroxine level cause increased aromatization of testosterone into estrogen, which cause increasing androgenetic tone. Thank you.